webinars in partnership with the Better Health Generation. I work for the IEP. I'm the chief exec here. Most of you know me. And thanks to Kylie and the team all the way on the other side of the world. Can you believe it's actually night time there while Kylie's doing this? It's really great. This week's webinar, as you all know, is Understanding Common Mental Health Conditions. I'm sure it's going to be as insightful as the other two webinars that we've had already. And if you want to look at the rest of those webinars, you can head on over to the IEP YouTube channel, where you'll find lots of interesting content. Make sure you do sign up for the rest in the series when the links are published through the IEP Learning Network e-bulletin, which comes out every Wednesday. You should have had one this morning. Please stay well, stay safe, and make sure you're chatting on the link there. It's really nice to hear from you, really nice to understand what you're up to and what you're doing. And remember, once again, that all the webinars will be on the IEP YouTube channel when we've finished this one, and you can get the other two already. So over to you, Kylie. Thank you very much to you and the team, and look forward to some great learning again.
Thank you, Scott. I thought I might take this opportunity to just reflect on the last couple of webinars. There has been quite a lot of chat, which we love, because there are definitely two important roles that the IEP plays. One is around educating frontline staff, but secondly, it's around networking. So after this event, I'm going to leave the chat open for the next 15 minutes to give you all a chance to connect and network via chat. You can direct message people who are enrolled in the webinar, but I think it's important that people continue to chat and continue to be socially connected. So I'll turn off my screen, but by all means continue to chat, and we'll keep the chat going as long as everybody needs. So firstly, for those of you who weren't on the last two webinars, I thought I might introduce the Better Health Generation, and hopefully at this stage you can see my screen. But I am the founder and managing director of the Better Health Generation, but I'm not the only person. We have Natalie Keating, our CEO of the Better Health Generation UK, on the line, and Andy Milne, who is our National Partnership Manager. The group of organisations that I run are all connected by a single purpose, which is to make sure that we help people to achieve their full potential. I'm a clinical psychologist, and many of my staff are also psychologists, physiotherapists, dietitians, exercise physiologists, nurses, occupational therapists, speech pathologists. So almost every discipline that you could think about to help people to achieve their full potential is part of the Better Health Group. We apply these skills across both to job seekers, but also to organisations, because we know that making sure that you are happy and healthy is the best way to impact a larger group of job seekers. So the last two webinars were particularly focused on you and making sure that you have all the extra resources that you need to perform the best you can at this new time, as I'm calling it. So enough about the organisation, let's just recap. Last week I spoke about the RISE model. I spoke about making sure that people stick to a routine, and I gave a couple of ideas about a daily task list that might be helpful for you to follow. We also talked about using this time to improve yourself, and many of you contacted me afterwards to ask me for the website edX.org as a way of micro-credentialing and upskilling yourself online during this time. I guess the goal there is to make sure that you come out of this situation the best version of yourself. We also talked about strategies for socialising and increasing social connectedness, and being part of this webinar today is part of obviously socialising, which is why we're giving you a bit of extra time at the end. And lastly, we discussed my favourite strategy, which is evaluating your thinking and making sure that you're using helpful thinking strategies. And as a bit of a summary for those of you who weren't there, we talked a lot about the glass is half empty and the glass is half full. What kind of thinking style do you have? and how do we reality test that and check that on a daily basis to make sure that the anxiety or stress or other intense feelings that we might be having can be moderated slightly at this time. So that was kind of the last week's session as a bit of a summary, but I thought this week's session, to mix it up a little bit, we might do a little bit of micro-credentialing, if you like, and talk a little bit about mental health conditions, talk a little bit about the myths that might be out there, and certainly just a bit of an overview of the different types of mental health conditions, and try to clarify any of those crazy diagnoses that I often see on Netflix or anything like that, and just demystify those for you. Today is not about how do you deal with those mental health conditions. It's not about how I help a job seeker with those mental health conditions, but we will be including those two topics in later webinars for you. Today is just a summary overview for you to have some upskilling and ask some questions. So let's just start with the myths about mental health and particularly depression. One of the common myths is it's a modern problem and it's growing. That's actually not the case. It's a rare problem. We know it's not a rare problem, and I think all of us on the webinar today are aware of that. I must be stupid or silly. That's probably a myth that we often hear, certainly for patients or job seekers, normally over 55, you know, who may not have grown up in an era where it's okay to talk about your feelings. That I might snap out of it. That's a really common myth as well. You don't snap out of a mental health condition. I must be going crazy. I say this commonly, that it's very normal to hear a voice in your head. When it becomes abnormal is when it starts telling you to do certain things, or you see or hear things that aren't there. That's when it's abnormal, but certainly you're not going crazy if you hear that voice in your head. People with a mental illness can't contribute to society. In fact, we know that people with a mental illness are great workers, and in fact work is a fantastic remedy for anyone with a mental health condition. People with mental illnesses always need help. Well, that's not the case either. People with mental illnesses don't have real illnesses. People with mental illnesses are violent or dangerous, and people with mental health need to be cured before they return to work. That's not the case at all. In fact, whilst you're working, you can address some of your mental health concerns. You don't need to be cured of mental health. I thought this was quite a humorous slide. There was a survey in Britain discussing mental health in the workplace, and the survey results showed that 30% of us are more comfortable talking about relationship breakups. And in fact, 18% of us are more comfortable talking about sex, and only 13% of us are comfortable about talking about our mental health. So it's quite surprising that mental health still today in the UK, and particularly focused on our own personal mental health, is not a topic that we regularly discuss. I'm not sure if the current circumstances might change that. I hope, as optimistic as I am, that is the case, that we all start talking about mental health and it becomes a normal topic of discussion. But only time will tell, and I guess those of us on the line today will be at the forefront of making sure we do discuss mental health. Let's talk now a little bit about feelings of sadness. I'm hearing every day, and I don't know if it's because I'm a psychologist or just that I talk to a lot of people, but I'm hearing that people are suffering from depression, I'm hearing people say that the current situation, the lockdown, all of that is causing me to be depressed. And I thought it might be helpful at this time to just distinguish between what is depression and what is sadness, because I have no doubt that at the moment some normal feelings of sadness are probably creeping into some parts of your day. What I want to make sure you're aware of is what the difference between sadness is and a mental health condition called major depression. Firstly, when you diagnose somebody with a mental health condition, they need to have significant distress and impairment in a range of areas of their life. So that means socially, occupationally, and other really important areas such as relationships or family. When you're sad, you often may withdraw, but you don't always have impairment across all of these areas of your life. The duration of symptoms are a little bit different too. We would normally see with sadness that you might feel a little bit down in the dumps for a couple of days, but with a significant mental health condition, you would normally have a loss of interest for at least 2 weeks straight for all parts of the day. It's also important to notice that sadness and depression also come with a lack of interest in all things. So you would find no interest in Netflix, which I'm hearing is quite common at the moment, but you'd also find no interest in eating and engaging with others on top of just feeling sad. The other thing about a mental health condition is there's often no trigger, and there doesn't need to be a trigger. We know at the moment we're in a normal state of stress and anxiety and sadness based on the pandemic and the lockdown and the circumstances of that for you. So mental health is probably a little bit different in that space. And there's also a permanent sense of worthlessness and guilt and hopelessness that would normally be associated with a major depressive disorder. Many of us at the moment feel a sense of sadness and grief about the current situation, but we still maintain our self-confidence and we still maintain the fact that we're not alone in all of this, and there is certainly other people out there across the world and across your neighbourhood going through the same situation. So depression is very different in that sense, that you feel alone, you feel isolated, and you feel like you're the only one going through this. I mentioned about the disruption to life and the and that we don't find anything pleasurable or interesting. Certainly there's a lot of overeating going on in my house. I can't work out why everyone goes to the fridge so regularly, but why we have to keep going to get food as well. So whilst people are adjusting, there are different ways that we respond to this situation. The other thing is that a depressive disorder or episode would also generally come with, and potentially, sadly, also come with some suicidal thoughts and behaviours. So if we're trying to distinguish between what is sadness and what is major depression or a mental health condition about the current circumstances, and I'm certainly not saying that none of you would be impacted or your families would be impacted with a depressive episode at this time, because it is a vulnerable time for everyone, but that is the distinction. Those 5 points are the distinctions to note. And that may also change the response that you take should someone be experiencing those 5 extra factors that I've just included on the screen. So there's different causes of mental health conditions, and no one cause has been definitive here. There's certainly some biological factors, there's certainly some psychological factors, and there's certainly some environmental factors that go on. Mental health for many people is different, and the way they experience it or the cause of it may be different, and it also may be none of these. So I think the evidence is very inconclusive at this time. So let's talk about the types of conditions within the mental health spectrum. Depressive disorders. Depression is the most common mental health condition, with approximately 1 in 4 in the UK experiencing depression at some stage of their lives. The symptoms are on your screen, but it needs to diagnose to diagnose depression, you need to have that first symptom, which is the depressed mood that doesn't go away for all of the day, most of the day, for at least 2 weeks. And again, remembering it needs to have a significant impairment in your social, occupational and other areas of your life on top of that. There's a loss of pleasure and interest and motivation, sense of despair, and normally a change in your sleeping, eating and activities of daily living. So we'd normally expect to see an underreporting or an over-reporting of some of those types of conditions. There's a really strong correlation between depression and anxiety, with more than 50% of people who have a diagnosed depressive disorder also having an anxiety condition on top of that. This is my favourite slide, I always say that, but this is potentially the slide that's had the biggest impact on me as a psychologist, because it really clearly defines what is the difference between bipolar and major depressive disorder. So let me just explain this graph a little bit more. If normal mood was here along this straight line here, and low mood, very low mood, was right at the bottom here, and very elevated mood was right at the top here, we see that bipolar goes high into a mania phase and then goes low, which is where you get that circling of moods and behaviours. That's bipolar 1, and the only difference between bipolar 1 and bipolar 2 is that there's a hypomania phase rather than a mania phase. We see too that bipolar 2 actually goes lower in mood, so we would notice a little high but then a significant low, and normally where you would also see some suicidal behaviours down the bottom here. You can see major depression here, which is what we were just talking about with the symptoms, how you start with a normal mood and then you can go down just a little bit low, go back to a normal mood, but then go down to what we call a major low in relation to your mood. And in that diagnostic category, that would be called the major depressive episode that you've had. There is also another type of depression which we call persistent depressive disorder, which is just a minor low mood for a really long period of time, but it's not significant depression and it's not an episode that drops you down. And with a persistent depressive disorder, you normally need to feel low for at least 2 years. So it's quite a different type of depression. This slide really helps you to differentiate as a clinician where to intervene as well. We know that we can help people if we can track what's the antecedent or the trigger, if you like, to the high that the individual's having and the lows. So normally in treatment or assessment, you would try to graph and put this on a timeline so that we can provide some type of break, if you like, to the pattern of the cycling up and down. Because we know people with bipolar and we know people with depression can work. It's about moderating these highs and lows a little bit and controlling those. So what's the difference between major depression and grief? Grief is obviously our reaction that we have to either a loss or death. Grief is also a diagnosed condition, but it's normally the way that we adjust to grief that makes the event become slightly problematic to our mental health. So we would normally expect to see in grief a normal adjustment period of about 3 months. and obviously there's a significant loss. After 3 months is when we start to see if some of the mood and behaviours become persistent. It's where counselling or intervention at that time can help. But you can see here how there's a significant difference in the thoughts between grief and depression, whereas depression looks more around self-criticising and pessimism than what we're talking about with grief, where your self-esteem tends to remain fairly intact. Let's talk now about anxiety, because we know that 50% of people with depression also have anxiety. So there is a physiological response that we have to anxiety, and there's a psychological response, and there's generally a behavioural response. You can see on the screen now the types of physiological responses that we have. Again, varying intensity for varying types of people. The definition of anxiety, as I had mentioned in our earlier webinars, is where the level of risk that you perceive is higher than the actual risk, and you then get an increased anxiety response. So we can see here it's excessive worry, that then obviously if you have really high, you perceive yourself to have a really high risk of something bad happening, you tend to get excessive worry about that event actually going on. And that's really the psychological process going on with anxiety. There are at least 6 of the most common anxiety disorders at the moment. We've got generalised anxiety, the most common one, which is where we worry and have anxiety about generally everything, which is what the description details. We have panic disorder. Anyone with anxiety that has panic will be diagnosed with panic disorder, not generalised anxiety disorder. So the panic attacks are the defining feature between differentiating those 2 of the most common anxiety conditions. We've probably all heard about panic attacks, and the problem that we have is that once somebody has a panic attack, as an example in a shopping centre, is that they then avoid the shopping centre, and then they start to have anxiety about potentially having a panic attack, and the anxiety then becomes about the potential of the panic attack, not the actual panic attack that happened. And the ongoing increasing avoidance of the shopping centre never lets the person test out whether they actually ever will cope back at the shopping centre. So it becomes quite a cyclic type of condition, and it is probably one of the most debilitating types of conditions in this spectrum of anxiety. We have agoraphobia as well, which is the fear of going outside. We have social anxiety, which is probably more common than we would expect. And this is the fear of negative evaluation from others. And that's the defining feature between the anxiety types, is that people who have a social anxiety don't want to go outside, but they don't want to go outside because they have a fear of negative evaluation. It's not that they don't want to go outside because they think they're going to have a panic attack and other people will look at them. It's that they're scared other people will evaluate them negatively. And then specific phobias. I've probably got one of these with the snakes and spiders. So there are some people that have a fear of lifts, elevators, those types of things. So specific phobias are probably less common and as I said, almost less debilitating as well in a way. Most often with anxiety, you will have a primary diagnosis in one of these. It's unlikely that you have multiple diagnoses in these conditions here. You may have a primary diagnosis of depression, as I said before, and a secondary diagnosis of anxiety here, but you never really see someone that has generalized anxiety disorder and agoraphobia. One kind of supersedes the other in their diagnostic criteria. But if you were trying to notice somebody that had anxiety or depression, there are certain symptoms that you would notice at home or at work. And here's some of the defining features: the conflict, the avoidance, poor motivation, the withdrawal, the hopelessness, poor performance, increased mistakes, poor decision making, some vigilance, potentially some neglect around their appearance, and limiting their range of activities that they get involved in. So post-traumatic stress disorder is also in the anxiety family, but in order to be diagnosed with PTSD, you need to have experienced or witnessed, and more recently we have included the heard about, so the vicarious trauma, an event that threatened your life or the safety of you and or the life of somebody else or others, and that witnessing of that event led to significant intense feelings of helplessness and horror. On top of that event, we then need to have multiple of these symptoms down here. So there's a range of symptoms such as nightmares, sleeping difficulties, irritability, lack of concentration, and so on. So the diagnostic criteria says that we now acknowledge that if you hear about these events multiple times, that you may in fact meet the criteria for that diagnosis, as long as you have at least 4 of these on top of actually witnessing the event. And again, remembering the diagnostic criteria includes needing significant impairment in your social, occupational and other areas of your life. OCD is also in the anxiety family. In the OCD cycle, we normally see clients who might be obsessed with some type of distressing situation, such as, and the most common ones are germs or someone's safety, which leads to feelings of anxiety and then some repetitive behaviours that try to alleviate or relieve the anxiety. But unfortunately, the cyclic nature of OCD means that we then continue to do more of these behaviours and look for more of these distressing events, leading to more compulsions and so on. So a great example of OCD is where somebody has a germ phobia, which leads them to feeling anxiety about germs, compulsively washing their hands, which gives them some relief, but then they are heightened to the germs and then again the compulsions. Schizophrenia and bipolar disorder and psychosis. I can talk about this all night, so I'm just conscious of people's time, so I will rush through. But psychosis is normally the result of delusions or false beliefs that actually aren't true. I do commonly get the, in employment services, particularly in Australia, we get the person with the conspiracy theories or writing to the Prime Minister or those types of events. And often, sadly, they are based on delusions. There's hallucinations, so that's seeing, hearing, or smelling something that's actually not there. And then there's the disorganised speech and behaviour. So all of the conditions described in the top of this screen are associated with a psychosis. So if somebody, a job seeker, was to present with any delusions, hallucinations, or disorganised thought, it would almost likely be linked to these conditions here. These conditions here are actually mutually exclusive, and sadly, I often see job seekers that would say, I have schizophrenia as well as delusional disorder, and then they list bipolar as well. So they're often misdiagnosed as well, because the timeline for some of these delusions, hallucinations and events is sometimes clouded by drug use and also clouded by the client's history. If you were to diagnose someone with schizophrenia, as an example, the most effective way to do that, you need to have 2 years of history, really detailed history from the patient or the job seeker. And the first diagnosis is schizoaffective disorder first, until you get the 2 years of ongoing delusions or hallucinations or disorganized thought. So sadly, a good diagnosis is often difficult to ascertain when you don't have a lot of money and you are on the poverty line, really. Eating disorders, anorexia, which I'm sure we're familiar with, is a severe restriction of food. Bulimia, which is binge eating, and followed by some behaviours to prevent the weight gain, which could either be vomiting, laxatives, diuretics, or excessive exercise is another common one. It's important to differentiate here that somebody's weight often doesn't determine whether or not they have an eating disorder. Certainly with anorexia, if somebody's weight drops below a certain level, they do need to be hospitalised. But someone's weight doesn't predict whether or not they have a condition such as an eating disorder. Substance-related disorders, this is a little bit different to a drink on a Friday night or a drink on a Tuesday night, but substance-related disorders are normally continuous substance use, drugs, alcohol, prescription medication over a long period of time. The main criteria there is that you create a dependence, and a tolerance starts to happen with the number of drinks or number of smokes that you might have. And then that tolerance then leads to a withdrawal phase. So really what we're looking for here is the ongoing use and a tolerance that you create from it, and then some withdrawal symptoms when you're not having it. For those of you who know a little bit about this type of stuff, there is only one substance that you cannot withdraw from without medical attention, and that is alcohol. It can be, you can die from withdrawing from alcohol on your own, because your organs begin to function with that level of alcohol within them. So, yeah, I always think that's interesting, because there's a lot of harder drugs obviously on the market apart from alcohol. But yeah, that is the one drug that you need hospitalised detox for. Suicide, I think, obviously, and risk to yourself, we do see people who cause deliberate pain and injury to themselves, and sometimes it's a way of coping with their extreme feelings. But certainly if you know someone or you have a colleague, the kinds of signs that you'd be looking out for is cuts or burns, withdrawal, talking about feelings of hopelessness, a preoccupation with death, reckless behaviour, abnormal sleeping patterns, really dramatic changes in mood, excessive drugs or alcohol, and previous attempts of suicide are obviously precursors to potential difficulties with managing extreme emotions. There are some other factors that influence people's, I guess, pervasiveness to move towards suicide as a way of solving the problem of their mental health condition, and because they see no other way of solving it. And some of those are affected by age and sex. So men are actually 3 times more likely than women, probably because we can talk till the cows come home, women, about it, but men tend to bottle it up a little bit more. Age is also a factor. Young people are unfortunately suiciding more regularly than older people. This is a slide actually from Australia. So there's certain cohorts of Indigenous people who are more prone to suicide. And also, if you've lost a friend to suicide, you tend to be more prone to choosing that as an option to solve your problems. There's a couple of other examples here. So what are the treatment? I'll quickly move through the treatment because we're right over time already. I just want to point out that work is a treatment. So if somebody was in a good job and in good work, it does improve their mental health. Cognitive behavioural therapy is normally the class 1 evidence for the treatment of most mental health disorders. If you've heard me talk before, I talk quite a lot about work CBT, which is the class 1 evidence for mental health disorders and unemployment, because remember, none of these mental health disorders often come on their own. And I've included in this slide couples therapy, because if you've got one partner who's depressed and the other partner who's not, the most effective evidence shows that couples therapy would bring the couple closer together and help that person to deal with their depression, rather than one person going off on their own and emotionally growing without the partner, which kind of makes sense, doesn't it? But couples therapy is actually prescribed for that condition, because mental health just happens and occurs with so many other factors in our lives. We've also got interpersonal therapy as a prescribed intervention for depression, anxiety and grief. Schema-focused therapy, eye movement desensitization and reprocessing for PTSD, and obviously medication for other types of psychosis, bipolars, mania, hypermania, and some other schizophrenic type disorders. So just a quick note here, because we are all socially isolated at the moment. There's actually really good evidence before COVID-19 for the effectiveness of video call and telehealth intervention. We see it for a range of conditions. We see it for physical activity, PTSD, insomnia. We see it effective for older adults, ADHD, psychosis, lower back pain, and other types of health conditions. So this is just the research evidence that's being tested here, but by far and large, we know that telephone intervention or video call intervention is just as effective. I'll make a note there that there's really early research to say that video call intervention with daily monitoring and iCBT type interventions via app technology is almost doubling the effectiveness of outcomes in treatment. And that makes sense because we're including multiple components to the therapy to help the person to achieve their full potential. And I'm sure you're not surprised to know that that's one of our tools, which is Your Health Plus. So before I finish up, I just want to make a note that if any of you on the line are concerned about your mental health or feel that anything that I've said today specifically might relate to you, I'd like to encourage you to access some of your own help. And there is a range of different helplines available to you at the moment where you could receive telephone therapy or at least support services and be directed into the right service to help you. Psychological intervention, when it's done really well, is effective and does help people to improve their mental health. Getting the assessment right is a critical factor, though, to how successful your intervention will be. I might finish by saying that one of the most important factors in psychological intervention is the relationship that you have with the person that's delivering the intervention for you. About 50% of the way that person engages with you it'll be 50% of the difference in the intervention. So don't be too concerned if you're meeting someone and they're not launching straight into CBT or they don't know anything about schema-focused therapy. What's most important is the relationship that you form with that person. So that is about all from me. That was my really quick overview, and I'm sorry I've gone over time, but I might just ask Helen if there's any questions.
Hi. Yeah, we've had a couple of questions, one of which was on the chat, and it was that one of the participants was aware that alcohol misuse could lead to Korsakoff syndrome. And are there any ideas of how around that? That was the way it was broached. So any ideas around that?
Yeah, so Korsakoff syndrome is more related to alcohol use during pregnancy, excessive alcohol use. So you would have a child born with essentially a cognitive impairment based on, not the fetal development hasn't been as effective because of the excessive alcohol use. But what you do get with excessive alcohol use is, parts of the brain do die off. So you do have a cognitive impairment, which some people say, well, is it chicken and egg? Were they born with Korsakoff's and they never really knew it, and then they developed an alcohol disorder, which then caused them to have cognitive decline? Or was it that they didn't have Korsakoff's and then over time they actually developed an intellectual impairment based on their alcohol use, which is mimicked by Korsakoff's? So I think that's a really good question. But the main predominant feature there is the intellectual impairment, and that could be global impairment, or it could be more based on the frontal lobe, which would then cause problems in emotions and their reactions. And we sometimes see people becoming abusive because they can't manage those reactions.
Okay, interesting, thank you. And then we had another question that came through on the Q&A, and that was, how can we help someone who has depression and has become withdrawn?
Yeah, that's a good one. You'll have to dial into my next webinar for those ones, because today was really about an overview. But if you're particularly concerned, I encourage you to access the link that's at the on the last page, because there are support services there for family and friends, as well as the person who's suffering from depression. But we will be discussing that after the Easter break.
And there was one other question that Natalie actually answered on the Q&A, but I thought I'd share it with the group in case they hadn't seen it. And it was around how you would recommend supporting mental health and wellbeing at work with the HR team working from home. There's been a circulation of coping mechanisms and encouraging communication, but just any ideas for other things that people could be doing. And Natalie shared that there's been staff webinars and home working techniques, motivation and performance focused seminars that have been provided by the Better Health Generation UK, so people can access that.
Yeah, and certainly contact Natalie or myself or Andy if you'd like more information. I think we gave a short teaser of the Thrive model and the Rise Up model in the last couple of weeks. But if there's a more detailed people strategy that you want to implement within your businesses, please contact us. I think it's really important that organisations and employers adopt engagement strategies and communication strategies during this time, because the more that we can take the uneasiness out of our return to work and our working life at the moment, I think that the better it is for us all.
Excellent, fantastic. And for those, I know we've said it in the chat, but for those who weren't able to attend the last couple of webinars at the time, they have all been uploaded to the IEP YouTube channel, and this one will go up in the next 30 minutes as well. So if anyone wanted to refer back to those models, again, they're able to do so straight away. Thank you, Kylie.
No, thank you. And thank you to the IEP for letting us present. I know I've given you a lot of information today, and it is about micro-credentialing. I've touched the tip of the surface, and I promise in the next few weeks we will be providing another webinar to talk about how to actually deal with and work with clients with mental health conditions. So hold that thought. Thanks, everybody. I'll leave the chat going for at least the next 15 minutes so you can have a virtual network. I know you don't have a coffee or a cup of tea, but a virtual network with some of your peers and continue on chatting. There's been over 110 chats so far. So keep it up. It's social connectedness during social distancing. We love it. So thanks, everybody.